Okay, so I'm going to talk about venous disorders. There's 3 types: venous thromboembolism, venous insufficiency, and varicose veins. When you have a venous thromboembolism, it's a blood clot that has formed because of venostasis, endothelial injury, or hypercoagulability, known as Virchow's triad. If you remember the acronym thrombosis, you will remember your risk factors. So your risk factors are trauma, hormones, road traffic accidents, operations, malignancies, blood disorders, and hypercoagulable blood disorders like polycythemia, obesity, old age, orthosurgery, serious illness or sepsis, immobilization, or splenectomy. Your clinical picture, you're going to have leg swelling, redness, warmth, leg fatigue, and increased pain with walking. Your test, you're going to have D-dimer as the test. It is not really a test with a high specificity. It has a lot of false positives. So if the D-dimer is elevated, they're going to do a like an ultrasound of the leg. If they're concerned about a pulmonary embolus, they'll do what's called a CTA. Now, please do not get confused with prevention versus treatment, okay? To prevent a blood clot, you're going to do movement, TED hoses, and SCDs, as well as anticoagulation therapy. To treat a blood clot, you do not want to massage the affected limb. You do not want SCDs, but you can use compression stockings. You can apply warm, moist compresses, and they might prepare for possible surgery. It just depends on how big the DVT is. If they prepare for surgery, they're going to do a thrombolysis, where they're going to administer a thrombolytic directly to the blood clot. There is a question in practice right now about encouraging rest in DVTs. I know that your book talks about it, talks about putting them on bed rest, but it's not something that is 100% in practice. Like, they are thinking they're doing early ambulation with DVT patients. So I will not test you on something that is questionable. So encouraging rest is kind of a questionable practice right now, and it's not something that I see in practice. All right, so to prevent a VTE, they will do a low-dose molecular weight heparin. To treat a VTE, they will also do a low-dose molecular weight heparin or give IV heparin. If they're going to prevent the VTE, the low-dose molecular weight heparin will be like 30 milligrams, 40 milligrams. But for treatment of a blood clot, it's 1 mg per kg. So it's a lot larger dose. The low-dose molecular weight heparin can be given sub-Q, and you can actually go home on it. The one that we use in this area is called enoxaparin, but there are other low-dose molecular weight heparins. So if it's given IV or if it's given sub-Q in a large amount, it's going to prevent further clot development because it's going to increase bleeding time so that you don't develop clots, basically. But it will not work on getting that clot dissolved. Like, it does not do that. The only way to dissolve that clot is to do thrombolysis to that clot, where they administer a thrombolytic like urokinase or streptokinase. And Miss Brannon talked about thrombolytics this week. Now, there are significant adverse effects to heparin. One big adverse effect, is called heparin-induced thrombocytopenia. And basically, it is a hypercoagulable state, which I know is kind of contradictory to what heparin does, but that's what it is. And it's noted by a decrease in baseline platelets by 50%. So, you need to pay attention to what their platelets are trending when you're taking care of patients that are on a low-dose molecular weight heparin or a heparin. The blood, the two labs that you want to pay attention to are your PTT and your platelet counts. A PTT is going to look for dosing. Your therapeutic PTT, so what you want your PTT, is 1.5 to 2 times a baseline. That is if you're on an anticoagulant. 1.5 to 2 times the baseline. So a baseline is supposed to be 30 to 40 seconds. So 1.5 to 2 times baseline, you would times those numbers. So 30 times 1.5 would be 45. 40 times 2 would be 80. So 45 to 80 would be your therapeutic. The higher the number, the longer the clotting time. So if you're on an IV heparin and you do a PTT and the number is like 100 seconds, you're going to decrease your heparin drip. If you do a PTT and your number is like 20, you're going to increase your heparin drip. So the bigger the number, the longer the clotting time. The half-life of heparin is 60 minutes. You want to look at your platelet counts. If your platelet is less than 100, then you're going to not administer the heparin. You're going to either stop it if it's IV heparin, or you're going to not give the sub-Q injection, and you're going to let the provider know. There is an antidote available. It is called protamine sulfate. And you also want to do some education with your patient. If the patient is getting IV heparin or sub-Q heparin, you want to let them know that it increases bleeding. So patients who are at an increased risk of falls need to know to call for help and call for assistance, because if they fall and hit their head, they could bleed and die. So patients need to be aware of these things. If you have a patient that's confused, you can't really explain it to them. You can try, but they might not retain the information, and you need to keep a closer eye on them. If you want to educate your patients to rotate their injection sites, you want to educate patients to use a soft bristle toothbrush, to not shave with a manual razor, to use an electric razor. You want to educate patients to monitor for abdominal bruising. And anticoagulants are always, always, always given in the belly. So this is just a picture of what HIT looks like. So if they want to do thrombolytic therapy, it has to be started within 5 days of the clot developing. So the way you do this is you administer it directly to the clot, so you're going to go to surgery. So your actions are going to be monitor for bleeding and educate on bleeding precautions. So I've talked a lot about low molecular weight heparin. It's given sub-Q, and it's weight-based if it is to treat a VTE, so 1 mg per kg. If it's prophylactic, it's 30 milligrams, 40 milligrams. And I've talked about your considerations. You instruct to observe for bleeding. The bleeding precautions need to be taken. You rotate your sites because it hurts. You need to alert them for significant bruising, and you need to check for platelets and your PTT. If you're giving enoxaparin, which is Lovenox, you want to give that particular anticoagulant in the love handles. All other anticoagulants go in the abdomen. They go nowhere else. So another medicine that you're going to put somebody on, or the doctor's going to put somebody on, not you, is warfarin. Warfarin it takes a while to get a good therapeutic effect, so you're going to start warfarin while you're on heparin. It takes about 3 to 4 days to get the therapeutic effect. So with warfarin, you want to monitor their PT and their INR. You also monitor for bleeding. You want to educate them that it prolongs bleeding. It prolongs bleeding time, so they're going to be more at risk for bleeding. The therapeutic INR is 2 to 3. So normal is 0.8 to 1.1. A therapeutic is 2 to 3. Warfarin is something where they get their PT and INR drawn a lot until they level out between 2 to 3. And then it's, monthly. But when they first get on warfarin, it's, once a week, twice a week until they get situated. There is an antidote, and that is called vitamin K. So you want to teach them to avoid any sources of vitamin K or to not increase their consumption. Now, if you have a patient who eats collard greens, like they have been eating collard greens, then it's okay for them to continue eating collard greens. You do not want them to increase their consumption of collard greens. You want to educate them on observing bleeding to make sure that if they, have a laceration, that, they need to apply pressure for longer than normal. And if that applying pressure doesn't help, then they need to come to the emergency room. All right, the surgical management of a VTE is a thrombectomy with a possible placement of a vena cava filter. And what the vena cava filter does is it's going to filter large emboli and prevent a pulmonary embolus. So this is just a picture of what a vena cava filter looks like. It goes into your inferior vena cava, and it is to trap basically any emboli that would travel up into your heart or your lungs. So venous insufficiency occurs, I misspoke in class and said that varicose veins was this, but venous insufficiency is incompetent valves. And it occurs secondary to these incompetent valves in the deeper veins of your lower extremities and allows pooling of blood and dilation of the veins. The vein is not able to carry fluid and waste from the lower extremities, and this causes swelling, causes ulcers, and sometimes it will cause cellulitis. Your risk factors for venous insufficiency: sitting, standing in one place for too long, obesity, pregnancy, and a thrombus associated with inflammation. So with venous insufficiency, you're going to have leg swelling, skin color, texture changes, and venous ulcers. With varicose veins, you're going to have bulging veins. So the nursing care of venous insufficiency: avoid crossing legs, remove constrictive clothing, but wear compression stockings. Constrictive clothing can cut off your circulation, but compression stockings actually help promote circulation. So don't get those confused in your head. Elevate your legs a few times a day, and elevate them above the heart in bed, because this is venous, not arterial, so you want gravity to help return to the heart. So don't confuse. With arterial, you don't elevate above your heart. With venous, you do elevate above your heart. Your interprofessional care for venous insufficiency, you might have wound care involved because of the fact that they will have venous wounds. You might have dietary involved to help with nutrition so that the wounds heal better. And then venous stasis ulcers are going to, require long-term management. So you might have home health involved as well. So varicose veins are enlarged, twisted, superficial veins that occur in any part of the body. They rupture. Your risk factors are being female, over 30, and prolonged standing, being pregnant, being obese, having a family history. So the treatment for varicose veins is a sclerotherapy. So in varicose veins, you see that the walls are weakened and it doesn't close correctly, but with healthy veins, it does close correctly. Your expected findings are limb pain that is aching and a feeling of fullness or heaviness in your legs after standing. And this is vein stripping. So what they do is they strip the vein that is varicose, maybe is the word I want, to help basically aesthetics. It's not anything to do with health at all. It's more an aesthetic thing, as is sclerotherapy. I didn't really get to talk about this in class, but you can also have lymphadenitis, which is inflammation of the lymph areas. So you see that it's actually traveling up the arm, and that is traveling up the vein up to the lymph nodes. You can have lymphedema as well. And lymphedema is your lymph system is not able to return fluid to the circulatory system. People that are at risk of lymphedema are people that have had a mastectomy with lymph node removed. So anytime that they've had lymph node removal, they're more at risk for lymphedema. So in the arm, it's more associated with breast cancer, and in the leg, it's more associated with chronic thrombophlebitis or varicose veins, and it's like an obstruction of the lymph nodes. And then we can have cellulitis as well. And cellulitis can happen with venous stasis ulcers, but mostly it's an infection of, cellulitis happens with venous insufficiency. It can happen with venous insufficiency, which is why it's in the cardiac system, but it's an infection of the skin. And the most common bacteria that cause this infection are staph and strep. And basically you just get like a nick in the skin, and then you start getting swelling and redness and pain. And then systemically, if the infection gets systemic, you can get fever and chills as well. So it just depends on how severe the case is as to whether or not they do outpatient or inpatient. It can be managed outpatient if it's not too severe, but if it is severe, guess what? You're going to have IV antibiotics and be in the hospital. So this was venous issues. I hope that this has helped. If you guys have any questions, please do not hesitate to ask.